Now, today I'm going to do a review in mitral regurgitation, especially with a focus on functional MR, because as we know, functional MR is much more challenging than a primary MR in terms of echo evaluation. I have no disclosure. So the heart valve team is a multidisciplinary team made up of structural valve interventionists, cardiovascular imaging specialists like us, cardiovascular surgeons, anesthesiologists, valve clinic coordinators, and nurses. In functional MR, there are two types of transcatheter intervention, repair or replacement. There are so many devices now available in clinical trials. Here I only list a few, and the first one is a mitral clip or Pascal device. The second one is the cardioband that to reduce the annular size, and then the Carino device also reduce the annular size. And then for replacement, we have an Intrepid valve, and we did a couple of cases with Edwards cardiac Q. As we know, like there are three important clinical trials we need to know. The first one is a mitral French study. The second one is a COAP study. And then the third one is a reduced FMR trial. So we know the results of the two trials, the COAP and French study, are very different. And to save time, not going through these details, but the mitral French trial shows no significant difference between the trial groups with respect to the rate of death or heart failure hospitalization at 2 years. And for COAP trial, in the other hand, showed a significant lower rate of hospitalization for heart failure at 2 years, and also the significant lower rate of all-cause mortality at 2 years. So echo plays important role in pre-procedure assessment, procedural support, post-procedure follow-up. For pre-procedure assessment, we know transthoracic echo is used for diagnose the mechanism of MR and quantitate the severity of MR. And transesophageal echo is used to confirm the mechanism and the severity of MR, and also used for planning and guiding the intervention. I mean, that's the intro procedure, but for pre-procedure, it's good for planning of the intervention, the device choice, and the prediction of the complications stuff. And then last, for asymptomatic patients, sometimes we use the stress testing and to evaluate the LVRE contractile reserve and the PA systolic pressure, etc. So first, let's focus on the diagnostic mechanism of MR. As we know, the etiology of functional MR includes ischemic and non-ischemic MR, which is Carpentier class 3B. And if there's an annular dilatation, then that's Carpentier class 1. And this model shows that on the right hand, on the left panel, it shows this is a MR because of LV remodeling. You have a ischemic or non-ischemic cardiomyopathy, and usually with systolic LV dysfunction. On the left panel, this is because of a left atrium remodeling, and then you have AFib because of AFib or HFpEF that cause the MR. And in this model, then you have a mostly normal systolic LV function. And this is an example shows on the right panel, left panel, this is due to the LV systolic function, LV remodeling, and the right panel, you have a normal LV size and function, but the left atrium is severely dilated. So that's due to MR, due to the left atrial remodeling. Dr. Paul Grieben brought up this conceptual framework about proportionate and disproportionate functional MR. Basically, in proportionate MR, MR occurs because of a lateral but a symmetric displacement of the papillary muscle, resulting in an equal tethering of the mitral valve leaflet. In disproportionate MR, the MR is occurs because of unequal or discoordinated contraction of the papillary muscle that leading to asymmetric valve closure. And this shows patient with disproportionate MR will benefit from device or mitral valve intervention, and patient with a proportionate MR or non-severe MR will not benefit from the device intervention. So for all patients with functional MR, we need to give appropriate medical and device therapy, like CRT device therapy first. Then if MR still remains severe, then we consider the mitral valve intervention. Next, we're going to talk about the quantitative severity of MR. So as we mentioned before, secondary MR is much more challenging compared to primary MR in terms of grade. ASC Guidelines listed the criteria to diagnose the severe MR based on mitral valve morphology, left atrial size, left ventricular and atrial size. For qualitative Doppler, we have we look at the color flow jet area. We look at the flow convergence zone. We look at for semi-quantitatively, we look at the vena contracta width, pulmonary vein flow pattern, mitral inflow pattern. For quantitatively parameters, we look at the EROA by 2D PSIA, the volume, regurgitant volume, and regurgitant fraction. But we know all these parameters, especially some of them are really error prone, and we know clinical trial rely on calculation of the EROA, even though it's based on the assumption about the geometry of the regurgitant jet, is influenced by the transvalvular pressure gradient and the LV ejection fraction. So to accurately assess the MR severity, it should really be done using integrative approach that incorporated multiple parameters. So here I'm going to focus on several parameters that are error prone. The first is the jet area and the ratio of jet area to the left atrium area. It's included in the guideline, but my suggestion is it should not be used, especially in functional MR because it can be really misleading. For example, the patient in the upper panel has a lower blood pressure, and as you can see, the patient in the lower panel has a higher blood pressure, but both two patients have functional ischemic MR due to posterior leaflet restriction. The EF, LVEF is at 30%. Very similar appearance, the eccentric MR jet directed laterally. And the patient, because the patient on the top panel has a lower MR velocity and has a lower blood pressure, so the EROA is calculated, has a lower peak velocity, the mitral regurgitant velocity, and the calculated EROA is 0.3 square centimeter. Regurgitant volume is at 42. And instead of the lower panel, the patient has a higher blood pressure, has a higher regurgitant flow velocity of 6 meters per second, and then calculated the EROA is only 0.08 square centimeter, and the regurgitant volume is also lower, only 17 milliliter. So despite the similar MR jet appearance on color Doppler, the patient on the top panel has moderate MR. The patient in the bottom panel has mild MR. So you can imagine like a large needle with lower intrastenostic velocity produces smaller jet area versus a thin needle with a higher intrastenotic velocity produce larger jet area. You can imagine that. In this slide, you can see the effect of color gain, Nyquist limit, and transducer frequency has the effect on color jet area. With a higher color gain, you have a bigger jet area. With if you lower the Nyquist limit, you have a bigger jet area in the left atrium. And if you increase the transducer frequency, you will see the bigger jet area. So when you evaluate the MR jet area, you really have to pay attention to these settings. Next is the vena contracta. When we measure vena contracta width, it should only be measured in a peristernal non-axis view. And vena contracta is supposed to be independent of flow rate and the driving pressure. And it can be used for central or eccentric jets, and usually it's accurate in acute MR. However, it's not valid for multiple jets. And if a vena contracta width is over 0.7, we say it's severe MR. And if it's less than 0.3, we say that's mild MR. But the problem is with the primary MR, you will have a circular vena contracta area and hemispheric PSIA. But in functional MR, as showed in the lower panel, you have a elliptical vena contracta area and a non-hemispheric PSIA. So if we look at PSIA calculation, PSIA is not a typical hemispheric in functional MR. So the severity of MR can be overestimated if we measure it at the flattened face. The flat, you see, since it's elliptical, so depending on which angle you pick. If we pick that flattened, the red window, then you could overestimate the EROA. If we choose the green window, and we could underestimate the EROA. And so we know also in multiple jets, both the width, the vena contracta width, and the PSIA are not additive, so you cannot just add them together. And in this slide, you can see that again, functional MR and it's the vena contracta area. It's elliptical. It's not circular, and based on tau E wave and the CW signal, it's dense, and you look at from different angle, look at the flow convergence zone. This is you have completed two different vena contracta ways in these two plane. And this is what I mentioned, the flattened the surface. If we measure the EROL, we do the PSIA from this view versus we're gonna overestimate the EROA, and in this plane we're gonna underestimate. So as we know, with the 3D PSIA quantification, it's more accurate than 2D. Earlier, I showed you with a 2D example. Then you have depending on which plane you are measuring. But with the 3D, the automatically consider the whole, the real, shape of the PSIA, and it's supposed to give you more accurate estimation. And this is done by Siemens eValve software. And next is reverse the pulmonary vein flow. And we know reverse pulmonary vein flow is a sign of severe MR, but it's not really common in severe secondary MR, because blunting of a pulmonary vein flow is very common in LVEF reduced patient, because you can imagine the left atrium pressure is elevated, left atrium is very dilated because of AFib or left ventricular systolic dysfunction. And sometimes jet direction can influence if it's very centric jet, they may not it may not affect the pulmonary vein that is far away from the jet direction. So very commonly we see in this secondary severe MR, we see the blunted, like a severely blunted systolic pulmonary vein instead of a reversed pattern. And then CW, Doppler intensity. It's if the density is comparable to that of anti-growth grade flow, and they suggest a significant MR. But we have to make sure that the jet formation is adequate, to it has to be parallel, align with the ultrasound beam. And then regurgitant volume. So we know there are many factors can affect the accuracy in terms of regurgitant volume measurements. So if we calculate the regurgitant volume by the PSIA method, then we measure LVOT, VTI, and mitral inflow VTI. Then we measure the LVOT diameter and the mitral annulus diameter, but that can be error prone, as we know, because the LVOT or the mitral annulus is not overshaped, even not a circular shape, it could be overshaped, and any small error in the diameter measurements can cause can exaggerate the error because the measurement is squared. The numbers, whatever number you get, will be squared. So the error will be also squared. That's the very important factor we have to remember. And then because we have assumption of the uniform of the orifice geometry and the flow profile, so that all can cause the inaccuracy in measurements. And another thing is the angle dependency of the Doppler. When we measure the VTI, we make sure it has to be aligned with the ultrasound beam. And as we know, this is the same with the 2D stroke volume. If we measure by the biplane, it's better than single plane. But the 3D, of course, stroke volume is more accurate than 2D, especially when you have a regional wall motion abnormalities. So in all trials, the regurgitant volume are measured much more higher than the stroke volume are much lower. Like across these trials, the EF is around 30, and then the stroke volume is actually quite low. And this one is this concept for the quantitative assessment of MR. I like this model to quantitatively grade MR, functional MR, because in this model, regurgitant fraction is a key quantitative parameter. As you can see, we know if the EROA is less than 2 square centimeter, regurgitant volume less than 30 mil, then we know it's low, it's mild MR, and it's low risk. And we know when EROA is over 30 and the regurgitant volume over 45, then we know it's severe. For MR, we know it's high risk, but in a patient with between the EROA between 20 to 30, regurgitant volume between 30 to 44, it's intermediate. It's like a moderate MR, but to further grade based on their risk, then we look at the function. We look at the regurgitant fraction. If a regurgitant fraction over 50%, then that means it belongs to high risk. Then we would consider this is severe. Would consider to intervene, either medical therapy or after medical therapy still regurgitant fraction over 50, then we consider to do intervention. The reason is in functional MR, so the stroke volume is really reduced, and then your regurgitant volume, maybe it's low, but with a very low stroke volume, your regurgitant fraction is probably still very significant. That's why those patients need to be separated out. The last, my topic is device-specific mitral valve assessment. So by doing TE before the procedure, we need to see, we need to examine the leaflet, see whether there's a restriction, any calcifications on the leaflet, there any cleft, perforation, that will help the intervention to decide which device to choose, which intervention approach we need to get. And also for functional MR, we need to see the coaptation gap, length, and depth, and also the jet, origin of the jet, and the direction. And we need to get the mitral valve area. If it's small, then we're not gonna do a edge-to-edge repair, because in that way you're gonna further reduce the mitral valve area, and you're gonna cause MS. And then we also measure the annular size, see how much calcification on the annulars. That will help us to decide if the annular reduction, mitral annular reduction, can help with the mitral regurgitation reduction. And then we also look at the subvalvular apparatus because you want to see the cord and the papillary muscle tethering. You want to see how tethered they are. And then, if it's too tethered, then the clip or the edge-to-edge repair may not last long because it's gonna further separate away with the time, and you may have a problem to bring the leaflet together, or has early recurrent MR. And then next, we definitely look at the LV EF, ejection fraction, and the LV size, and the left atrial size. And then last, we check for left atrial septum, interatrial septum. We're looking for any PFO, ASD, aneurysm, or hypertrophy, because some transmitral intervention, you have you're gonna cross septum. It's a transseptal intervention. So you cross the septum, and you cause the you have to evaluate this conditions to see whether the transseptal is an easy approach or there would be any problem. And then, of course, we have to check see if there's any thrombus in the left atrial appendage. If there is, then there's a contraindication to do intervention. And if there's a vegetation, of course, no, we are not gonna do that. Okay, so in conclusion, echocardiography plays an important role in pre-procedural assessment and interventional procedure support for functional MR. Understanding the mechanism of functional MR is important in patient selection for treatment, and the assessment of MR severity should be done using an integrative approach that incorporates multiple parameters, including semi-quantitative and quantitative methods.